Welcome to Medication Talk, an official podcast of TRC Healthcare, home of pharmacist letter, prescriber insights, and the most trusted clinical resources. On this episode, listen in as our editors discuss several novel drugs approved in 2025, including 2 new eye drops, a new topical for chronic hand eczema, and an oral non-hormonal option for patients with menopausal hot flashes. They'll review efficacy, safety, and considerations for use with these new treatment options. You'll hear from 2 of our pharmacist editors on our team at TRC Healthcare, Associate Editor Sara Klockars and Assistant Editor Stephen Small. This podcast is an excerpt from one of TRC's monthly live CE webinars. Each month, experts discuss challenges in practice, evidence-based practice recommendations, and other topics relevant to our subscribers.
And now, the CE information.
This podcast offers continuing education credit for pharmacists, pharmacy technicians, physicians, and nurses. Please log into your pharmacist letter, pharmacy technician's letter, or prescriber insights account and look for the title of this podcast in the list of available CE courses. None of the speakers have anything to disclose. Now, let's join TRC editors Dr. Steve Small and Sara Klockars and start our discussion.
Let's start off by looking at several new eye drops. First up is Aceclidine eye drops, or Vizz, for presbyopia. Before we dive into this med, it's worth talking about anatomy first, since we will be referencing several parts of the eye. Remember that the pupil at the front of the eye is the opening that allows light to come in and shine on the retina, which captures the image before sending it to our brain. And the amount of light is adjusted by opening and closing the iris. The lens, on the other hand, sits behind the pupil. Muscles around the lens can help it change shape and help it focus the image onto the retina so we can interpret it. With that in mind, what is presbyopia? It's what we call a refractive error, where patients have difficulty seeing closer objects. It typically starts occurring after our 40s as our lenses become stiff and less flexible over time. And it starts having trouble changing shape to help us focus on those close objects. So those close objects become blurry. And presbyopia is considered a typical part of normal aging, and there's no way to stop or reverse it. And it is common. About 1 in 8 adults in the US who are 50 years or older have near vision impairment because of presbyopia that is not corrected. Although we don't have a cure per se for presbyopia, we do have treatment options. A common one for most people is to use reading glasses, including those that are available over the counter. And some patients may need bifocals if they already use glasses to see distant objects. Plus, contact lenses are an alternative. And keep in mind that surgery is another option, but as you can guess, it's more invasive. We also have pilocarpine, 0.4% and 1.25% eye drops as an FDA-approved pharmacologic treatment option. These address presbyopia by constricting the pupil to better focus the image, also known as the pinhole effect, and can be used daily for mild cases. But pilocarpine has side effects such as headaches, eye redness, things like that, and the lower 0.4% concentration was developed in order to decrease some of these effects. Now we have aceclidine as another pharmacologic option, and it works similarly to pilocarpine as a muscarinic agonist, but it has a longer duration of action, which allows for less frequent dosing. And like pilocarpine, it constricts the pupil to better focus images on the retina. However, aceclidine is considered more pupil selective than pilocarpine. Let's talk about why that's important in terms of possible adverse effects. We talked about how images in presbyopia are focused behind the eye because of lens rigidity, making close objects blurry. Pilocarpine constricts the pupil to adjust for this, but pilocarpine also causes lens muscles to constrict, changing the lens shape and image focus, and as a result, you may have fixed the problem of blurry close objects, but now you have issues with seeing distant objects, known as myopic shift. Quite the trade-off there. Aceclidine's pupil selectivity is intended to fix this issue. By not affecting the lens muscles, it's thought that the selectivity helps patients maintain vision of those distant objects. But keep in mind, this benefit over pilocarpine hasn't been proven in head-to-head trials. If patients are prescribed aceclidine, there are some important administration points for prescribers and pharmacists to share. Patients should remove their contact lenses before administration and specify that they should wait at least 10 minutes after administration before putting them back in. Now, the dose for aceclidine is 2 drops in each eye, 1 time daily. Now, patients may want to rush through to get these drops in, but clarify that they need to be patient to get the best effect. Explain that patients should give 1 drop in each eye first, then wait 2 minutes, and then they can instill another drop in each eye again. And also, patients may be taking other eye drops. They'll need to space these at least 5 minutes after using aceclidine. And as we know, it's important to think about possible side effects here. Although rare, medications in this class can rarely cause retinal detachment, where the retina actually separates from the back of the eye. And this is an emergency and requires immediate medical help since it can lead to permanent blindness. But again, this is rare. Similarly, this class can also cause iris inflammation or iritis, especially in patients who've had this issue before. But there are also some minor side effects that are more common, but are temporary and thankfully usually go away on their own. For example, despite aceclidine's theoretical advantages, blurry vision is still possible. So it's best to advise patients to see how aceclidine affects their vision first, especially at night, before they try to drive while on this medication. It's also expected that patients may have dimmer vision, since after all, we are constricting the pupil, so that's going to let less light into the eye. And similar to pilocarpine, patients can have headaches, likely due to patients' eyes needing to adapt to focusing, which can be exhausting. In terms of role of therapy, expect aceclidine to be used for patients where non drug interventions such as glasses or contact lenses aren't enough to improve their presbyopia, or perhaps that these options are inconvenient. It can also be an option if patients have tried pilocarpine but had trouble tolerating or adhering to the regimen. Plus, the Vuity version contains benzalkonium chloride as a preservative, which might increase eye irritation for some patients taking pilocarpine. Aceclidine may decrease this risk since it's actually preservative free. But don't always expect significant financial benefits to using aceclidine. A monthly supply costs about the same as pilocarpine options, depending on whether pilocarpine is used once or twice daily. There are some other unique pearls about this med to think about. For example, each aceclidine plastic vial is intended for single use. Because it doesn't have preservatives, open vials shouldn't touch other surfaces or the eye, since that could cause contamination and potentially infections. But clarify that one vial should be used to administer doses in both eyes. Patients don't need to use one vial for each eye. Otherwise, that'll increase cost and waste. And the dispense quantity is also interesting here. Aceclidine comes in cartons of 25 vials, which is 5 foil pouches, each containing 5 vials. So essentially a 25-day supply, and not exactly a month. So a technician should check with their pharmacist before opening up another carton to get patients to a full 30 days. Thankfully, if you do open a carton, each unopened foil pack can be stored until its expiration date on the packaging. But keep in mind, unopened aceclidine foil pouches should be refrigerated. Use auxiliary stickers as a helpful reminder to staff and patients to ensure the med is stored properly. And once the foil pouches are open, they can be stored at room temp and used within 30 days. Ideally, advise patients write the opening date on the foil packs to help them keep track. Now, let's say that an aceclidine shipment was left out in your pharmacy at room temp for a day after delivery. Now, you might first think to just throw that supply away, but that's not always the case with this med. The manufacturer notes that the med can actually tolerate temps up to 104 degrees Fahrenheit for up to 8 days. So that might help you save supply and money. And we know it's always good to keep an eye out for cost savings. With that, I'll hand it over to you, Sarah.
Thanks, Steve. When it comes to eye care, I'm also not afraid to drop some knowledge. Next, we have Acoltremon or Tryptyr drops for dry eye disease. So, dry eye disease occurs when there is decreased tear production or increased tear evaporation. And when tears can't adequately lubricate the eyes, it leads to inflammation and surface damage, where patients can have burning, stinging, irritation, that sense of sand or grit in the eye. So, let's briefly review what happens with tears to help us understand how the meds can help. So, with normal tear production, the lacrimal glands continuously produce watery tear fluid to moisturize the surface of your eyes every time you blink. And the small glands on the edge of your eyelids, called meibomian glands, secrete an oil which then coats that watery tear and helps prevent tears from evaporating. So then tears will drain out of your eyes and into your nose through the tear ducts in the inner corners. So when we get dry eyes, we don't produce enough tears, possibly due to aging, medications, or we experience increased tear evaporation when those meibomian glands become clogged or don't secrete enough oil, possibly due to staring at screens and blinking less, or maybe makeup or bacteria gets in there. So, to manage that decreased tear production or increased tear evaporation, we want to first emphasize starting with non drug measures, things like humidifiers, sitting away from a blowing air duct, quitting smoking, and then trying to limit that screen time with the 20-20-20 rule, where you shift the eyes focus from the computer or phone every 20 minutes to something 20 feet away for 20 seconds. We also want to look at meds that may contribute to dry eyes. We want to look for anticholinergics like tricyclic antidepressants or amitriptyline. We also have overactive bladder meds like oxybutynin. And then before we go to prescription meds, we want to recommend trying OTC ophthalmic lubricants first, such as artificial tears, gels, or ointments. And when all of that isn't enough and patients still have symptoms, we have prescription meds. So we have our cyclosporin options, such as Restasis, to help decrease inflammation and increase natural tear production. We also have lifitegrast or Xiidra, which targets inflammation due to reduced tear production. We have perfluorohexyloctane, or MIBO, often for patients with meibomian gland dysfunction, to help stabilize tears and reduce evaporation. We also have varenicline or Tyrvaya, which is a nasal spray to treat eye symptoms. Yeah, you heard me right. It helps increase tear production. And then we have the new med Acoltremon or Tryptyr, which stimulates tear production. So Acoltremon is the first drug in a new class for dry eye disease. It's a transient receptor potential melastatin 8 or TRPM8 thermoreceptor agonist. So Acoltremon binds to these temperature sensitive receptors and activates nerve signaling, which leads to increased tear production. And it may also cause a cooling sensation to relieve discomfort. If a patient is prescribed Acoltremon, there are some important administration points. We want to be sure patients remove their contact lenses before a dose, then instill 1 drop in each eye twice daily, trying to space it out about 12 hours apart. And note that there is enough solution in this single dose vial for both eyes. And then wait at least 15 minutes after a dose before inserting contacts. If patients are using other eye drops, we want to be sure to separate them by at least 5 minutes. And when it comes to side effects, the most common side effect was installation site pain or burning sensation, which occurred in about half of the patients in clinical trials. So this could be more of that cooling sensation that it may cause when these drops are instilled in the eye. Some patients say it may feel like menthol or mint in their eye. So the good news is that it's usually mild, short-lasting, and tolerable, since less than 1% of patients stop the med due to this sensation in clinical trials. So let's see where Acoltremon fits into the bigger picture of managing dry eyes. Here you can see the current prescription options, how they work, and their approximate cost for a month's supply. And one of these is usually started after optimizing those non-drug measures, limiting meds that may be worsening dry eye symptoms, and treating with those OTC eye lubricants. When it comes to choosing one of the prescription eye drops, the choice is definitely individualized. So it's based on the symptoms, severity, patient and payer preference. And many of us are used to seeing cyclosporin tried first with its long track record, and it's the only generic option for now as well. So don't expect to see a lot of Acoltremon or Tryptyr yet. There's no proof it's any better. Comparative data are lacking. Plus, it's pricey, so anticipate prior auths. It may have a role when patients have tried and failed other options for dry eye, and it does seem to work fairly quickly, which is a plus as well. There are a few nuances with Acoltremon. It comes in a carton of 60 for a 30-day supply. And inside that carton, there are 12 foil pouches. Each foil pouch contains 5 single dose vials. So, similar to Vizz, these are single use vials and do not contain preservatives, so they should not be saved once they're opened. Also, if your pharmacy carries this, it should be kept in the refrigerator while it's in the pharmacy before it's dispensed. And then patients can store an open carton at room temp or in the fridge, but be sure to review beyond use dating with them. An open carton is only good for 30 days if it's stored at room temperature. So point to the place on the side of the carton to write the opening dates to help patients. Also, remind patients to record the opening date on the foil as well, since once the foil packet is opened, they should use it within 7 days. So keep the unopened vials in that foil until they're ready to be used as well. To help keep all of the dry eye meds along with their dosing and cost straight, be sure to see our treatments for dry eyes chart on our website. Steve, are there any audience questions we can answer for folks?
Sure, let's see what we have here. Here's a question about aceclidine. They ask, can aceclidine be used in kids? And this is a good question. So, presbyopia, by definition, only occurs in adults since it's associated with aging after our 40s. So, aceclidine doesn't have an FDA approved pediatric indication for kids. And this is a good reason to double check your patient's age and the indication when verifying or dispensing this med. And here's one for you, Sarah. One audience member asks, how long does it take Tryptyr to start working?
Oh, good question. Yeah, so patients report that it starts working as early as the first day. Usually it takes at least 2 weeks to see significant improvement. And so that 2 week mark is along the lines of when you see improvements with the lifitegrast and perfluorohexyloctane drops. So all of these seem to be quicker than what we're used to seeing with that cyclosporin, which may take 6 weeks to see some improvements and 3 to 6 months to see those full effects. So this one does work pretty quickly.
Yeah, great context there.
Okay, let's move along to our next drug, which is Delgocitinib or Anzupgo. It's the first topical cream approved specifically for chronic hand eczema in adults. So, briefly, chronic hand eczema is an inflammatory skin disorder on the hands. And it gets its name chronic because it's lasting for more than 3 months, or it relapses and comes back at least twice a year. And it causes itching, drying, cracking of the skin, as well as redness. It can be pretty painful. It's usually treated in a stepwise manner, so factoring in those patient preferences, costs, and severity. And that just means starting by identifying and avoiding triggers such as frequent hand washing, irritants such as fragrances or soaps, and then extremely hot water. We also want to encourage regular use of moisturizing ointments and creams and suggesting those fragrance and dye free options. And then, if more is needed, topical steroids tend to be the mainstay of treatment, and we may or may not see them used with topical calcineurin inhibitors like tacrolimus. So, in severe cases, we'll see patients on that UV light therapy or oral meds such as acetretin or cyclosporine. So now we have this new topical pan-Janus kinase inhibitor, Delgocitinib, and this blocks multiple types of those JAK enzymes to reduce inflammation and symptoms. So it's a bit different than the other topical JAK inhibitor you may see, Opzelura or ruxolitinib. And this med only blocks two enzymes and is approved for mild to moderate atopic dermatitis. It is currently in trials for chronic hand eczema as well. The thought is that this broader mechanism with delgocitinib may be more effective, but we don't have head-to-head trials yet to know. If patients get Delgocitinib, they should apply a thin layer twice daily to affected areas of the hands and wrists only. They also shouldn't use more than 30 grams per 2 weeks or 60 grams in 1 month. Also, it seems to have minimal systemic absorption, which may be why it doesn't have the same serious boxed warnings for clots or mortality that oral JAK inhibitors and the topical ruxolitinib have. But be aware, it is still linked to reports of shingles, rare infections, and non melanoma skin cancer. So, patients should watch for infections during and after treatment, still get periodic skin checks, limit sun exposure using sunscreen. It's not recommended to use this topical with oral JAK inhibitors or other potent immunosuppressants like oral cyclosporine, since there isn't any evidence that it's safe to do this. Also, side effects were rare in the initial trials, but you could see pain, itching, redness at that application site. So let's see where Delgocitinib fits for treating chronic hand eczema. I know you're itching to know. Thinking back to that stepwise approach, first limiting those triggers, using moisturizers, and then prescription med wise, we don't have a lot of options. We would probably continue to start with topical steroids with or without that calcineurin inhibitor. And then that leaves Delgocitinib basically as a last resort. So expect to see Delgocitinib when other topicals aren't enough and when patients want to avoid oral options or using that UV light therapy. Plus, just a reminder that it's only for patients age 18 and older, and it will likely need a prior auth, partially due to that price tag of about $2,000 per month for a 30-gram tube. But it is good to have another option available for patients with severe symptoms. I do briefly want to mention the JAK inhibitors approved for atopic dermatitis, as these may be used in some patients who have both atopic dermatitis and chronic hand eczema. And as I mentioned, Opzelura cream or ruxolitinib is in trials for chronic hand eczema. Plus, there are other oral JAK inhibitors used for conditions such as moderate to severe rheumatoid arthritis, ulcerative colitis, psoriatic arthritis, such as baricitinib. And these are important because patients shouldn't use Delgocitinib if they're on another JAK inhibitor or med ending in itinib. So we need to ensure patient profiles are current. And since most of these are specialty meds, remember to ask patients if they're getting prescriptions from other pharmacies. Also, if you get Delgocitinib prescriptions, clarify that use as directed SIG. It's usually used twice daily, but don't be surprised if it gets changed to PRN BID once patients get their symptoms controlled. There is a 52-week open label trial where it was used safely like this. And then watch quantities and refill histories. Patients shouldn't get more than 60 grams in 1 month. And also note that it is stored at room temperature. And remember, I mentioned rare cases of shingles with Delgocitinib use. So I'll use this as a reminder to try and complete those age-appropriate vaccines prior to starting this med. And if patients need live vaccines, wait to give them about a week after finishing this drug because patients should not get live vaccines right before starting, during, or right after treatment. To get answers about many more FAQs about treating eczema, see our chart online called Managing Eczema. It includes everything from prevention and non-drug measures we discussed to the role of systemic meds like cyclosporin for more severe eczema, and then everything in between. So now I'm going to switch gears and talk about Elinzanetant or Lynkuet for moderate to severe vasomotor symptoms or hot flashes and night sweats due to menopause. So managing menopausal hot flashes. Systemic hormone therapy has been the mainstay, especially for healthy patients under age 60 or if patients are within 10 years of their last period. And these replace that estrogen the body stops making during menopause. But Hormone therapy is not an option for everyone, such as patients with blood clots, breast cancer, or with a history of a stroke. Or perhaps there are patients who want a non hormonal med. So, for these patients, we can usually try meds such as an SSRI like paroxetine, an SNRI like venlafaxine, gabapentin, or in 2023, Elinzanetant or Vizz was approved. And even though they're not as effective as estrogen, they may still all offer some relief. But overall, more options are needed. Which brings us to the latest non hormonal option, Elinzanetant. So before menopause, usually there is a balance between estrogen and the chemicals in the brain, which keeps the internal temperature of the body in check. But during menopause, estrogen levels decrease, disrupt this balance, increasing substance P and neurokinin B, causing the estrogen sensitive kisspeptin neurokinin dynorphin, or candy neurons in the hypothalamus, to tell the body it's overheating, which leads to hot flashes and night sweats. But Elinzanetant blocks neurokinin 1 and neurokinin 3 receptors to reduce substance P and neurokinin B, which reduces the overactivation of the candy neurons. So ultimately, it will lead to a reduction in vasomotor symptoms. So think of Elinzanetant as similar to Elinzanetant, but Elinzanetant only blocks NK3 receptors. So, is Elinzanetant more effective since it blocks two different receptors? And how do these two meds compare? Well, patients can expect about 3 fewer hot flashes per day with Elinzanetant compared to placebo. And studies with Elinzanetant report about 2 or 3 fewer hot flashes per day when compared to placebo. Both of these options seem to work within 4 weeks, with some seeing benefit as early as 1 week. But we don't have direct comparison trials to say one is better than the other. But the thought is that Elinzanetant may impact sleep better than Elinzanetant, and studies are ongoing. If patients get Elinzanetant, we'll need to take steps to ensure it's used appropriately. Most patients getting Elinzanetant will take 2 60 milligram capsules or 120 milligrams orally once daily at bedtime. It can be taken with or without food. And just be aware that patients taking some interacting meds, such as fluconazole or diltiazem, may need a lower dose and should only take 1 60 milligram capsule at bedtime. And they'll need to carefully peel the foil to save that second capsule for the next dose. We also want to watch for other interactions where Elinzanetant should be avoided, such as with strong CYP3A4 inhibitors, such as itraconazole or ketoconazole, or inducers, such as rifampin. Patients should also avoid grapefruit juice while on Elinzanetant. It's also important to think about possible side effects. This med can cause headache, fatigue, somnolence, and dizziness, especially at first. And that extreme tiredness does seem to improve with time, but that is why it's important to take it at bedtime. This med should also be avoided in pregnancy, and use this med with caution in patients with a history of seizures. One patient with a history of epilepsy had a seizure in the trials. And also note that Elinzanetant can cause photosensitivity in some patients. There are also some other considerations. For example, it's costly at about $625 a month. So anticipate prior auths and that patients may need to try those other non hormonal options first. We do have some safety data after a year of use. Elinzanetant doesn't have that boxed warning for liver injury like Elinzanetant does, but advise checking those baseline and 3-month follow-up liver function tests until we have more long-term safety data. It's also important to note that Elinzanetant doesn't impact hormone levels or cause endometrial hyperplasia after a year of use. So will we see a lot of Elinzanetant? Probably not yet. Expect to continue to see systemic hormone therapy in eligible patients, especially for those healthy patients under age 60 or if they're within 10 years of their last period. If patients can't take hormone therapy or prefer not to, Then think of the non-hormonal options. Maybe worthwhile to consider a generic SSRI like paroxetine or an SNRI like venlafaxine before we consider that neurokinin B receptor antagonist, Elinzanetant or Elinzanetant. So this is a good reminder to make sure patient profiles are up to date with current meds and medical conditions when dispensing Elinzanetant. And that's to help identify patients at risk of seizures, ensure patients are not pregnant, and to catch potential interactions. Also, even though this med doesn't seem to cause liver injury, labeling advises not to start Elinzanetant if baseline serum transaminase concentrations are 2 times the upper limit of normal or greater. Another thing to stay alert for are look-alike sound-alike errors. Not only do Elinzanetant and Elinzanetant look similar, but then we have the neurokinin 1 antagonists that we often see as antiemetics, such as aprepitant. And for the pharmacy folks, be sure to use those proper auxiliary labels when dispensing this. Do not chew or crush these soft gelatin capsules. Patients will need to swallow them whole. Patients should also avoid grapefruit. And since this may cause photosensitivity, it's good to remind patients of sun protective measures. So to close this topic out, be sure to search our website for some helpful menopausal resources. We have a chart on managing vasomotor symptoms, and we're in the process of updating this to provide more information on the non-hormonal options. And then I also see a few questions on how to manage vaginal symptoms with menopause. So please search our website for our chart, Managing Genitourinary Menopausal Symptoms, for answers to many of your questions. We have info on vaginal lubricants and moisturizers, as well as vaginal estrogen products. I think you'll find it really helpful. And then if you start to get more questions, or if you've already gotten more questions on menopausal hormone therapies with the labeling changes, we have an interactive printable chart with brand names, dosage forms, and so much more. Steve, any more audience questions we can try to answer quick?
Yes, we do. Here's a question about Elinzanetant. Can Elinzanetant be used in patients who've had breast cancer?
Good question. The short answer to that is yes. The longer answer is that there's actually evidence in a recent OASIS 4 trial that Elinzanetant can be used safely in patients with hot flashes and a history of breast cancer, or if they're taking endocrine therapy for breast cancer prevention. And so after 4 weeks of use, patients experienced about 3.5 fewer hot flashes a day with Elinzanetant compared to placebo. So this is an option for patients. I know anecdotally, Elinzanetant has been used in this population as well, but there isn't robust published data in this population for Elinzanetant. But I do think we'll start to see more data on using these agents in patients with a history of breast cancer or having hot flashes on endocrine therapy for breast cancer prevention. That's a great question.
Great to have that data in mind.
We hope you enjoyed and gained practical insights from listening to this discussion. Now that you've listened, pharmacists, pharmacy technicians, physicians, and nurses can receive CE credit. Just log into your pharmacist letter, pharmacy technician's letter, or prescriber insights account and look for the title of this podcast in the list of available CE courses. On those websites, you'll also be able to access and print out additional materials on this topic, like charts and other quick reference tools. If you're not yet a pharmacist letter, pharmacy technician's letter, or prescriber insights subscriber, now's the time. Sign up today to stay ahead with trusted, unbiased insights and continuing education. And as a listener, you can save 10% on a new or upgraded subscription with code MT1026 at checkout. Be sure to follow or subscribe, rate, and review this show in your favorite podcast app. Or find the show on YouTube by searching for TRC Healthcare or clicking the link in the show notes. You can also reach out to provide feedback or make suggestions by emailing us at contactus@trchealthcare.com. Thanks for listening to Medication Talk.